We are
Thanks.
almost ready to start, and I'm very grateful that you are standing in for Dr. Mkhize. I'll give you opportunity just now to explain. Dr. Mkhize phoned earlier today, his office, to say that he's not well, but on short notice, Dr. Buthelezi, the Director General of the Department of Health, availed himself to be with us. And I also think that Advocate Sibu Ngubane, the Chief of Staff, is also with us. Am I right?
Yes, good afternoon. Good afternoon.
And so welcome. We are very pleased that you are joining Dr. Buthelezi. They say two is a crowd, so thank you very much for availing yourself. Okay, ladies and gentlemen, we are going to start. We are discussing this very difficult topic of the COVID pandemic. And our guest tonight, as I said, will be Dr. Buthelezi. Now, he himself is a medical doctor, and he joined the Department of Health with a wealth of experience. He worked in the implementation and rolling out of government strategy to fight HIV, TB in our country. He also worked with international organizations that have over the years given support to South Africa. So may I start by asking you, Dr. Sandile, will you just give us a short background about yourself? How did it come that you are DG?
Thank you very much, Anton, and good evening once more, and good evening to my colleague, Sibu. It's a very difficult question to start with, but a bit of a background. I'm a medical doctor by profession with postgraduate training in health services management and general management and business administration. And I started with the Department of Health 3 months ago, but prior to that, I was the Chief Executive Officer of the South African National AIDS Council since 2017. And before then, I was actually the country director and the head of Africa for ICAP at Columbia University, which is based at the Mailman School of Public Health in Columbia University in New York. And I was responsible for rolling out the FIA studies in 17 African countries. The FIA studies is actually the surveys on looking at the public and population-based impact of HIV in different countries. Before then, I worked for DFID, which is the UK government support to African countries. And then prior to that, I spent 18 years of my life working for the Department of Health in KwaZulu-Natal. At different levels, I did my internship, worked as a medical doctor, a clinician. Then I was a medical superintendent, what is now called COs, for 2 hospitals. One district hospital in Nkanda, which is a 265-bed hospital. Then I was promoted to run Gray's Hospital, which is a tertiary hospital, one of the 3 tertiary hospitals in the province. And thereafter, I started as a director for HIV in the province from the year 2000 until I was promoted chief director in 2004. I also worked as a regional chief director and have chaired the REC, which is the Research and Ethics Committee for the University of KwaZulu-Natal, and have participated in a number of fora internationally and regionally. And also with my previous job, I actually chaired the country coordinating mechanism for the Global Fund in South Africa, which means that it's a body responsible for the application, the management, the disbursements of funds under the multilateral body called Global Fund, which is based in Geneva. Roughly, that is my story as Sandile Buthelezi.
No, that's very impressive. It's really impressive indeed, and I can understand why you are appointed. It almost appears as if you are handpicked, but I can see with experience you are an asset as a DG. So, Dr. Buthelezi, I want to start tonight by asking you, what is the current status of the pandemic in South Africa?
Yes, thank you very much, Anton. As you all are aware, South Africa was hit by a storm with our first case registered on the 5th of March. And honestly, before I take you through the route, we were very happy that our government was decisive and acted in a very good way by implementing lockdown towards the end of March, which allowed us to prepare and be able to study and manage the epidemic. At that time, it was very difficult for us because we did not have much information except some few cases from China and from a few other countries. So we needed to be sure what to do. At that time, that's when then as a country, we were able to start implementing the community-based screening so that we went out fully, got almost 10,000 community-based workers doing screening of the people and testing so that we would understand at the same time building the health system at that particular point in time. Of course, it was very difficult because it was the first time we had such an epidemic in South Africa. We wanted to make sure, depending of course on statistics and information that we got from the modelers in terms of predicting where we could be going as a country. And cases started declining at that particular time in terms of the doubling time of the virus, moved to about 15 days, having been less days than that. But obviously we couldn't stay in lockdown for very long. We're able then as a country, of course, in favor of trying to ensure that people are able to get back to work and look after their families. And then there was a gradual reopening of the economy. Then we started to see some infections increasing, especially towards end of May, starting in June. And then we started to peak, but at different provinces. At that time, the province of the Western Cape was the province that we didn't expect was going to peak first. It was immediately followed by Gauteng, but of course, a lot of containment measures under the leadership of the NCCC and of course our own Minister of Health. And it increased and other provinces followed. We implemented different strategies, but more importantly, knowing that there's no vaccine, number one, there's no treatment except supportive treatment. We're able then to focus on non-pharmaceutical interventions. We've seen then the infection then tailoring down, though we're still increasing as a country. I mean, at one time, in the middle of July, towards the end of July, we were number 5. We climbed to number 5 in the whole world. But now we've moved to number 7, and we think we're going to be dropping even lower down the scale in the whole world. But where we sit now, as at yesterday, our infections, new infections of what we look every day, yesterday we had about 1,890 new infections. Remember, at the peak of the pandemic, at one time we went to 14,000 new infections. For the past 2 weeks, we've been sitting between 2.5, 1.5 infections. I mean, we've gone to closer to 1.2 at one time. So we're monitoring that. But now, just to come back to your answer, I wanted to give you just a bit of a background. As at yesterday, we had total cumulative cases of 636,884 with recoveries at 561,000, which is 88% recovery rate. Of course, sadly so, we're still losing a number of people. So our total cumulative deaths is sitting at 14,814. It's a big picture, but if you look at international rates in terms of case fatality, which is the people that pass away, divided as a denominator by a total number of cases, there's about 2.2, 2.3%, which is almost half of what the case fatality rate is in most of the countries. And then in terms of the total tests that we've done as a country, we've moved very hard to ensure that we test as many people as we can. So we literally, as of yesterday, we tested more than 3.7 million people in South Africa, and we're still continuing to test to see if we can get there. Maybe I can stop there, sir. Thank you very much.
Okay, as a follow-up, DG, tell me, to what do you attribute the fact that numbers are declining at the moment?
Yeah, my apologies for that one. It's a very difficult one. We're still studying. We can't say with certainty that these are the issues. But more so, one, we still believe that the communities are being responsive in a way in terms of taking care of themselves through the implementation of non-pharmacological interventions. That's your social distancing, washing of hands, cough etiquette, staying away from crowded places. We think there is a response that we're getting from the different communities. Of course, with such high numbers of cases, we can't say that for sure. We will be doing a zero survey very soon, where we will be trying to look at the community, what is the level of infection. Because one of the speculations which we've not proven is the issue of herd immunity, which we want to try and see how many people have been infected. Because remember, there has been probably a number of people who were infected but did not show the symptoms and also did not test. Then they have the antibodies in their blood that might be protective. We can't say that with certainty, but once we've done proper zero surveys and looking at that, we could be able to answer. But we also believe that it might just be the natural cause of the epidemic in itself. I mean, you would have heard what my minister has been saying, together with actually the clinicians and the specialists, that for example, in the Western Cape, the infection started tailoring off, but we know that it was so difficult in managing the infection in that area. It was difficult to quarantine people. It was difficult to get people to adhere to non-pharmacological interventions, but the infection is definitely on the decline in that area. So it's one area that we're studying more, that will have much more certainty, but not discounting that people are listening. People can see that this is a serious infection and are looking after themselves.
Good. DG, I think the reason for that question is because schools reopened, and we would imagine that would also, in a sense, increase the infection rate. But thank you for that answer. Let's move to the next question. Tell us about the reliability of data, the data that you use to establish the parameters of this pandemic. Because we have concerns, it seems to me as if there's a clash when it comes to data.
Yes, it will be difficult because you might be trapping me. I don't know what the clash might be, but let me just be frank with you. The kind of data that we're using, starting from the testing information, we've developed a very good system between ourselves and the private labs, where in everyone that gets tested, all the information, there's a system called LIMS, which is Laboratory Information Management System, that each and every registered lab, whether private or public, must use that system. Then the data of the test is then triangulated through the central database of the National Institute of Communicable Diseases, which is a very credible institution, by the way. So we pull that data there, so we're able to know for people who've tested both in the public and in the private sector. So that, of course, then the positives as well, we pick them up from that data. However, there might be, with every test, whether it's for HIV, whether it's for TB, there are possibilities of sometimes, in some instances, of some false negatives or false positives. That's allowed because normally you don't get tests in terms of what we call sensitivity and specificity that are 100%, they will be in their 90s. So on that, obviously, there will be issues, but we are very sure that what we report is what we get from the laboratories linked to both the public and the private sector. Similar with the deaths, we're really yet dependent on the reporting system from the hospitals in terms of all the deaths that they get, and then obviously the certification. And of course, the certificate, there is a particular methodology that is WHO approved that we use to certify deaths and also record the death as a COVID death or a COVID-related death, based on what the doctors say clinically, but also on the positive test that you get. So that is actually the clinical certification of death that we use. Then we calculate those numbers and we put them in. I am, however, aware that you will probably, your follow-up question might be what is called excess deaths. So let me rather maybe handle that right now. That, of course, there has been reports from the Medical Research Council, which is, by the way, our own institute for research, where they've actually been monitoring the deaths, looking at the historical data of deaths and what is happening, looking mainly at the unnatural deaths. There's a phenomenon that's international, that's used internationally, where they see that at this particular time of the year, based on historical data, we're expecting that we might, or we're predicting that we'll have deaths of this number, but this time we've seen these deaths around. We're following that one up. It's something international, and it doesn't have all the answers around that, but until that time that we've been able to do the proper analysis, and the proper analysis of deaths are done by Statistics South Africa. As we are aware that when someone dies in a hospital, they fill a form called BI 1663, which goes to Home Affairs, and then the other part gets into an envelope. That envelope is not even opened. That's where the actual cause of death, it then goes to Stats SA. Unfortunately, there's always a lag in time in that it's done after about 2 years. Then you get the definite numbers. And Stats SA will then be able to help us to answer that question if all those other deaths were definitely COVID-related or not COVID-related. But also the other data that has been argued about is the data of healthcare workers who are infected in terms of those numbers. Again, we've tried to address that, where we've actually linked our testing data to what we call the PESAL, which is the payroll numbers of people which are linked to IDs. So we're able to overlay that data into all the tests, and it will tell us if everyone had put in an ID number. It will tell us if that person was a health worker based on their PESAL number. That's how they get paid. Otherwise, they wouldn't be paid without that number. So in that way, we are able then to know that so many healthcare workers are infected, and we think that's credible enough. Thank you.
Thank you, Doctor. I want to know, move forward, change gears a little bit. As you are aware, churches are a bit concerned about the Solidarity Fund. It seems to us, when you listen to the news, that certain things escalated regarding this fund. So is it possible for you as a DG to take us quickly through the Solidarity Fund, how it works, the effectiveness?
It would be very difficult because I'm not the spokesperson of the Solidarity Fund, but from our own understanding of the Department of Health and from our own interaction with the Solidarity Fund, is that the Solidarity Fund was established by government to be able to pull together funds from the private sector funders to assist government to respond. And from our own understanding and from the website and from our meetings, they have a board that was selected, and in that board we've got 2 government ministers who represent government in the board, which is Minister Patel, who's the Minister of Trade and Industry and Competition, and Minister Mboweni, who is the Minister of Finance. They are actually part of the board. And our understanding is that from all the funds that they get, they support the interventions. And we've actually reached an agreement with them that through my office as an accounting officer, all health requests that we take to them, we actually screen them and we put them through to them, and we're able to get what we need. And I must say that we have benefited from the fund. I would not be able to talk about their own internal governance mechanisms, as I'm not that's not my competence. However, in terms of what we've asked from them to assist, so for example, they've managed to procure ventilators for us to the tune of 20,000. And what's very nice, which is a legacy project about those ventilators, is that we insisted that they must be procured from the government institute, which is called CSIR, which is helping us as a country as a legacy project, but is also ensuring that we actually catalyze the government capability of manufacturing for future projects, so that as a state, we are not dependent on the private providers all the time. They have also supported our testing through putting some money into our national health laboratory system, procuring the tests. They've assisted us with personal protective equipment. They've assisted us with some other equipment for the hospitals. But even the zero prevalence survey that we're about to do, it is going to be funded by them. And we are still in negotiation with them to fund some other things to help us. But as I mentioned, when it comes to other issues in terms of their governance arrangements, their accountability, it's a bit difficult because it's not within my competence. Thank you very much.
Thank you, DG. That's a good answer. I can see you are not a politician. Thank you very much for speaking clearly about this one. Let's come to the difficult one. When will churches be able to fully open? And by that I mean Sunday services, Sunday school, sacraments, singing. How do you envisage?
Yes, first place, I must just say that currently under level 2, churches are allowed to function. Unfortunately, the numbers are still limited to 50, and of course, in keeping with the health protocols. However, there was a meeting 3 days ago that was convened by the state president, His Excellency Cyril Ramaphosa, where he met different faith leaders, where they raised a similar question that you've just raised. And he did promise the faith leaders that he is going to actually get the different teams to look into this and come up with a recommendation to see how we can actually assist the churches to continue with their service, not as limited as it is currently. So that is being looked at the highest level. And we think that very soon the president will, once he's received all the inputs from the different technical teams, like the net joints, which is a team of director generals, of course, going to the National Command Council, will be able to pronounce on this matter. But his response was that it's going to be looked at as a matter of urgency. Thank you very much.
So what you are saying is there's a high possibility that within the next few days or next few weeks, maybe we will change and we will see how churches will operate on a more natural level. Is that what you are saying?
Depending on the inputs that are put through to the president, at the end of the day, the cabinet of the country are the people who makes the decisions based on the different inputs, scientific and the other inputs that are put in place. But the matter is being looked at, and I will not be able to pronounce on that until it's been done. But I'm taking direct from the president where he said this will be looked at, and government will pronounce on what the next steps are going to be. And he was very sympathetic towards the church.
Good. DG, at this moment, at this stage, of course it's true, we can gather 50 people, even funerals, restricted numbers, but we can't sing. We can't use the sacraments. Do you think that will change? I know it's a difficult one for you, but give us your view on that one. And before you answer, our next question will be raised by Minister Renier Schoeman, who was the Deputy Minister of Health under Mr. Mbeki. So first you answer this one, and then I'll give him opportunity just to come in with a question.
Yeah. Of course, what our cabinet looks at, as I mentioned, they get different inputs, looking at different variables. Of course, if there are some of the practices that are felt that they might still be making people prone to infections, those will need to be looked at. I will not be able to pronounce on those specifically because different religions function in a different way. For example, well, maybe just to declare my religion, I'm Anglican and strongly Anglican. And as Anglican, the way we take the sacrament might need to be relooked at because there's some contact and with different people, but other religions do it in a different way. So whatever will be put up, there will be specific health protocols that will be put in place to ensure that there is no exposure of people to the infection. But I would not be able to go through because I do not understand how different religions or different churches actually do the issue of the Holy Sacrament.
Thank you so much.
Also,
what now? Are you there?
Yes.
Are you there, Neil?
Yes, I think also, DG, maybe to also clarify, churches are singing right now. A number of services are being held, but obviously within the limited number of 50, but they are allowed to sing. There's no restriction in terms of singing. It's really what is important is the adherence to the health protocols. So for example, this morning I was, in my church service virtually, but it was exciting to just see, the leadership of the church within the building, and also there was basically full worship, and all of that was taking place live. So there's no restrictions in terms of singing. It's really like the DG is saying, that the adherence to the health protocols. For example, one of the issues have been around the sharing of, would it be proper? Is there no risk, for example, if a cup during sacrament is shared between, the congregants? Those are some of the measures that will need to be, enforced just to protect the congregants.
Thank you. Thank you so much. I want to open the line for Renier Schoeman. He's coming with the next question. And as I said, DG, he was Deputy Minister of Health under the leadership of Thabo Mbeki. So Renier, maybe you must switch on your camera as well.
If I can. I don't think I can. I think if I'm lucky, I've got a bit of sound, but I don't know how to get myself in the picture, which is unusual for a politician, but I'm trying.
Fine. Gustav, can you switch him on?
The gentleman put it on.
Okay. Renier, will you continue, please?
Yeah, I can continue, not a problem. No, I just like to really thank you, Sandile and Sibu, for your presence. And as much as we miss my dear good friend, Dr. Zweli, we are delighted that you've taken the trouble to be here. What I wanted just to ask is, it's actually just a more general question, and that is, what can we as citizenry, as citizens of the country, do from our side to support Dr. Mkhize, the President, and you and all your colleagues who are working so hard? What can we do from our side, would you say, to be supportive of that effort of yours? That's what we would very much just like to know. Whether we can actually do it or not, that's a separate issue, but we can try. I've made it back, yeah.
Thank you, Rene. You are back on the screen. I can see that. Thanks a lot. DG, you want to answer?
Yes, thank you very much, Rene, and thank you very much, Anton. Yeah, firstly, I must just mention that the church has got a very special place in the society. The church, one is you've got quite good membership, but one more critical issue about the church is that really the church is about behavior change. And one thing when we want to implement the non-pharmacological interventions is that it's about behavior change. And churches are well placed to actually be leading on that area to assist us to get people to change behavior, washing hands, social distancing, staying away from crowded places. And for me, the church, that is a niche of the church that you cannot take away. And for me, the church can help us so much in that one. But the second one is what we've spoken about, is that the churches should lead by example in terms of ensuring that whatever health protocols are in place, churches should not be the people who are actually contravening such health protocols, because churches are exemplary and the leadership in churches are always taken as the leaders that people listen to. The third part that churches really need to play, one of the difficult areas that we are dealing with now is that families dealing with death. People are dying lonely deaths because families can't go to see them in hospital because of the health protocols. I mean, you've got families that have lost people, they can't go and see them, and these people, they end up dying lonely. Even the burials, people can't even go to bury their loved ones. I mean, the issue of pastoral care and pastoral counseling is one thing that we think the churches should play a role, not only at that level, but also dealing with our own healthcare workers. Have been seeing people dying, seeing their loved one getting infected. That's when we need the pastoral care. That's where we need the chaplaincy of the church to assist sisters at that level through spiritual counseling, pastoral counseling, helping our people. So it's quite a lot of areas where the church can play a space that no other person can play.
Yeah, that's true.
Thank you.
Thank you very much.
There are two comments here thus far, DG. The first one is a question. They want to know, close relatives, can't they clothe themselves with PPE to be with dying people in their last moments? I think this is something that really caused some trouble. So this is the first question. Is there a possibility that maybe some of the regulations can be applied in a different way? And then the second comment was just to say thank you. You are answering the questions up front, and we really appreciate that. So maybe, DG, if you can answer that one, what about that dying moments of a dying patient? Because in fact, he can't be infected now anymore.
Yeah, it's a difficult one, Anton. It's a difficult one. I must say, in the early stages, and even now, you will all know that we struggled a bit because of the global competition in terms of procurement of PPE. And the PPE that we had, the priority was to get to the frontline healthcare workers, and they were the priority in terms of getting that PPE. So hence, it was limited, and it wasn't very easy to make it freely available to the people. But secondly, in terms of us getting in the people to see their loved ones, it's very difficult. It's a bit risky. However, it's something that can be looked at, but I'm not sure if it's going to work. We'll need to go think, but we'll also need to take it to our Ministerial Scientific Advisory Committee to advise us on how we can mitigate the risk of infection, because that is the main issue. But we do agree with you. I mean, those last moments, the dying moments without the family, and those are the things that are actually also taking a toll on our own healthcare workers, because they are the people around that are taking the toll from this. So it's some of the things
Absolutely.
that we always need to consider as we understand the infection even more.
DG, you've answered again according to what we expect from you. Thank you so much. I want to know, often in the news we hear this is the China virus. Do you think it's the truth? Is it the China virus? Is it manipulated?
No, we don't have any evidence to that effect. We all know that the first infections were reported in China, in Wuhan. Other than that, scientifically, that's all the information that we have. Any other information we consider it anecdotal until we have evidence.
Good. Second question. Do you think there's a possibility of a second wave of infection? We always hear how the minister warns South Africa they must be careful and vigilant because there's the possibility of a second wave of infection. What is it that your department mean by a second wave of infection? Because it seems to us as if some of the preventative measures are working, we are reopening the country, and it seems, even though we are reopening it, it seems as if the numbers are dropping.
Yes, yes, of course, we cannot discount the second wave or what we call the resurgence. But by the resurgence, we mean that we might get an increasing number of daily infections, just like it has happened in other countries. I mean, the two countries that we can quickly talk about is Spain. Spain had really crushed down their infections, but right now they've gone back to very high daily infections. It happened in the US as well. It recently happened in South Korea, but they've been able to manage it. So there is a possibility for us as well as a country. However, we're trying to learn from what led to the researchers in the other countries so that we can prevent it. Now, always coming back, you can learn from the other countries. So for us, that's why we're saying the fact that we're opening the economy doesn't mean that the virus has disappeared. So if we're actually not behaving properly, not taking the relevant health protocols into consideration, we stand a risk of actually getting a second wave. And that is very possible. We've seen it in other countries as well.
Advocate Sibu, do you want to come in here? Is there an extra comment?
Well, I thought I would comment right at the end.
You're welcome.
You know, because yes, the minister had just asked that we make sure that we do express his appreciation for the role that the church has played during this period. The religious community has been very cooperative. I know that literally at the beginning, if you remember, with the first reports, when there had been a conference in Free State, and there were numbers reported there. And government then made a decision that there would be restrictions even on church gatherings. And the church responded positively. They were supportive of government. In fact, the church came and said, how can we assist? Like Anton, you've been asking now to say, what can we continue doing? So the church has really played a critical role, and that needs to be acknowledged and recognized. And it's certainly a message that the minister has asked that we pass on today. But also just to apologize for him, because he's not feeling very well, but he would have loved, you know, to join this meeting, especially because we do believe that, you know, despite all the hard work and everything that one can do, that the minister and the whole government can do physically, but they also count on your prayers as the church to make sure that you pray for them, they remain in strength, they remain resilient even in tough times. And we do hope that you will continue praying for our government to continue with this fight.
Thanks a lot. Thanks a lot. DG, one last question that came in. It says, COVID has changed the way we run hospitals. We have diverted manpower to COVID wards and focused on COVID. How will this pandemic change our hospitals going forward and the health service we deliver?
Thank you very much. I think there are pluses and minuses in terms of what we're learning from COVID. But I can tell you one thing. There's one thing that I must just mention before I answer the question. is that the collaboration between the public and the private hospitals that we've gotten through COVID, it's just wonderful. I mean, we've got a number of provinces that have signed SLAs now, and this is a way forward for us, obviously, towards what we call universal health coverage. So that's what we're going to be doing moving forward and strengthening those partnerships. But coming specifically to our hospitals, what COVID has actually exposed is the chronic shortages of staff that we've been exposed to because of the dwindling pace in terms of finances, but also because of the supply of human resources. Because as we know that as a country, as much as we do want to have as many health professionals as possible, but the issue is that most of them are not there. So we're now looking at our strategies of production, increasing production in terms of all categories of critical healthcare workers, but also to do with the numbers that we have, but to also multi-skill our workers. You will notice that during the COVID-19, for example, we had to do training on people to work in ICU and be able to ventilate or intubate patients and actually be multi-skilled because we did not have those skills in the quantities that we needed. So that has helped us as a country to ensure that we've got good skills that we will need anyway, because anyway, to intubate, you don't only intubate for COVID, you intubate for any other thing that affects the respiration of a person. So we've been able to deploy people, and actually the efficiency of the use of our human resources. That's the other thing that we've learned, which is very positive. And also noted that, as I mentioned earlier on, one thing that we picked up is that if we actually work hard and actually rationalize our resources, we are able to cope. A lot of people had thought that South Africa were going to run out of beds. And let me tell you, we never ran out of beds. Even the field hospitals that were put in place based on the models and the predictions, we hardly fill them beyond 50% of bed occupants. That means we have enough facilities if we are very efficient and are able to use our human resources efficiently. Though it puts a bit of a toll on the current human resources, which at this point we must really take off our heads to the people that work in the health services and in the frontline healthcare services for the commitment that they put in. Some they worked longer hours. They went in there seeing some of their colleagues getting infected, but because they believe that this is a calling and they did the work and they're still doing the work even now.
DG, thank you so much. We came to the close of our conference. You answered upfront. I really appreciate that. I want to thank Advocate Sibu Ngubane, the Chief of Staff. Thank you for standing in at very short notice. I think you did a splendid job. We want to ask maybe one last question as a DG. In short, I see it's a comment coming. Did any good come from the virus thus far? We're not speaking about the corruption. We are speaking about any benefits. You as the head of the department.
Thank you very much. A lot of good things came. We learned a lot. You know, they say you must use every situation and get the positive out of it. I've just mentioned now that the kind of cooperation that we came up with in working with the private sector is unprecedented. And we can see we're now moving towards NHI strongly together with the private healthcare sector. We're able to plan together now and start putting things together. That's very good. But secondly, is doing things differently. I mean, we've just learned now, look, we're having a conference and it's a virtual conference, but if you had called this conference in terms of the costs, in terms of the traveling, the time, you know, it's a lot of good things that we've learned. And I still believe that we're going to learn even more, but also in terms of some of the efficiencies that we see we can build within the public health services. We've learned that we're able to pick up some of the issues, and also it has also enforced even interdepartmental collaboration with other departments. Like every Sunday we meet with the different DGs and we know what each department is doing. We're able to plan together and work collaboratively together as departments. So there's quite a lot. I will not finish. I can write actually a thesis on the good lessons that we are still learning as we're moving forward. The last one that I want to mention, which I don't want to forget, is the introduction of the ICT. The ICT that we've introduced now, including the COVID Alert app. And may I request Anton and all the clergy that are here please go and download the COVID Alert South African app. That's purely a government app. It's free of charge. It's on Google, it's on Apple, and you will read about it. You can be able to pick up if through the Bluetooth that if people have you've been exposed to the people who have been infected, if your apps were talking. So it's a lot. It's not the only one. We've created the COVID Connect also, which is an ICT platform. Now, for the first time, we've got the private labs. We know exactly what they are doing. They are reporting through a central database. It's a lot of good things, Anton. Thank you.
Thanks a lot. So we are going to close our meeting now. If you don't mind, I'll give you a phone call just now when we are done, just to express my sincere gratitude. So thanks for tonight. Thank you for giving us guidance. And our sincere prayer is also that God will guide our country in this turbulent time. Thank you once again.
Thank you very much, and you have a blessed evening.